Next speaker is Dr. Harold Burstein. He is at the Dana-Farber Cancer Institute in Boston, and Hal will discuss adjuvant endocrine therapy in postmenopausal women, risk stratification, type, and duration. I segued on purpose right into your talk, Hal.
Thanks, Dan. So the previous two sets of remarks from Angelo and Prue really set the table beautifully for a discussion of optimal treatment in postmenopausal women, and I hope to be able to successfully build on the themes of risk stratification and patient selection that they alluded to. Before I start my remarks, I wanted to just give credit to Aaron Goldhirsch, who unfortunately is not able to be with us at this year's St. Gallen conference, but his presence and intellectual force certainly looms large over my remarks in particular, and I think this meeting in general, with a focus on subsets, rigorous analysis of clinical data, global collaborations, and particularly the value of international consensus. So Aaron, we're thinking of you, and your presence, as I said, has very much informed what I would like to say today. So 3/4 of all breast cancer diagnoses are ER positive. The majority of those are in postmenopausal women, and for those patients, almost all will receive adjuvant endocrine therapy. With the help of one of my colleagues at Dana-Farber, Pablo Leon, we looked at the SEER data registry for 2010 to 2015. And if you break out the cancers diagnosed in early stage, you'll see that on the right-hand side of this pie chart, roughly half are what you might call, as a shorthand, as Dan likes to say, luminal A cancers. These are grade 1 or 2, stage 1 or early stage 2 cancers, so T1N0, T1N1, all lower grade. What's left? What's left is 1/4 of the pie that is split almost evenly between triple-negative cancer and HER2-positive disease, and about 1/4 of the pie, which is either stage 3 luminal A or luminal B type breast cancers. I'd like you to keep a visual of that through the set of my remarks because I'll come back to it at the end. What do we offer women in the first 5 years after their diagnosis? As this audience knows well, the historical standard was 5 years of adjuvant endocrine therapy, and the Oxford overview analysis shows there's an impressive improvement in recurrence and overall mortality. And subset analyses have failed to disclose a group which does not benefit from adjuvant endocrine treatment. Dr. Rugo discussed very nicely yesterday how we might think about the very, very lowest levels of ER expression, but for everybody else, there's a clear rationale for at least 5 years of treatment. Now, what about in an era when we have genomic subtyping available? This was a very clever analysis from an old trial, the Stockholm 3 trial done in the 70s and 80s, that looked at women who had 3 centimeter tumors or less, node-negative cancers, and who were offered tamoxifen for between 2 and 5 years versus nothing. And what they've shown here is the outcome by 70-gene mammoprint signature score for either the high-risk cancers on the left or the lower-risk cancers on the right. And what you can see is that adjuvant tamoxifen actually helps both groups equally. The hazard ratio in both groups is 0.42 or 0.46. There is a more significant statistical benefit numerically, not statistically, numerically, in the high-risk cases, of course, because as Dan was just alluding to, they are riskier tumors. But there is a major benefit for each type of breast cancer, luminal A or luminal B, or high signature versus low signature, for use of adjuvant endocrine therapy. It's also important to remember that adjuvant endocrine treatment is a critical enabler of de-escalation in surgery and radiation treatment. And Tim Whalen really spoke to this earlier today, but one of the reasons we can do less in the way of surgery, avoiding axillary node dissections, being less obsessed with margins, all those kinds of considerations, are principally because of the effectiveness of adjuvant systemic therapy, and for ER-positive tumors, that includes endocrine treatment. So in the overview, again, there's a dramatic reduction in the risk of local regional recurrence with the use of adjuvant endocrine therapy. And in particular, studies like NSABP B14 using adjuvant endocrine therapy reduced the risk of 10-year local regional recurrence by 70%. Even in the extreme cases of sub-centimeter cancers, adjuvant endocrine therapy can be valuable. These are data from NSABP B21, which looked at sub-centimeter cancers, node-negative. Women were randomized to tamoxifen, radiotherapy, or both. And there is measurable benefit for reducing the risk of in-breast events and contralateral breast cancer for the use of adjuvant endocrine treatment. Now, one might argue that it's not worth it to reduce the risk from 9%, say, to 2%. But that's a discussion. It's not a fact. Doesn't contravene the fact that endocrine therapy clearly does numerically lower that risk. So what are the risk factors for early recurrence in the first 5 years after diagnosis? Principally, they include anatomic stage, nodal status, and tumor size. They include grade, including semi-quantitative measure of ER expression, and if Beppe Viali is free after this meeting, he can run your Ki-67, but otherwise you can use your own, I suppose. And a variety of genomic signatures have been shown to be quite powerful prognostic features in terms of figuring out whether this is a higher or a lower risk recurrence cancer. So what do some more contemporary experiences look like in terms of choosing the optimal strategy? Here's a schema for Big 198. I think this trial is known to almost everyone here. It began as a two-arm study of tamoxifen and letrozole, and then also included crossover in both directions. And if you focus on the comparison of the aromatase inhibitor versus tamoxifen, you will see that there is a measurable numerical benefit for the aromatase inhibitors on the order of 2 to 3% in terms of distant recurrence-free or overall survival even, though that peters out as you get 14 years out. I would add that having just seen Prue's remarks, I think these data look very similar to what you see in the text analysis, and I underscore that because I think it makes the point that breast cancers that are ER positive diagnosed in younger women are not fundamentally different from breast cancers that are diagnosed in over age 50 women. Once you normalize for ovarian suppression, all those other differences kind of go away, and this will be interesting to discuss with Angela when we come to that point about the role of chemotherapy in younger women. If you want to be more precise about the measurable benefit of an aromatase inhibitor, it's on the order of 2 to 4%. Lower risk cancers that are node negative, it's about 2%. Higher risk node positives, it's about 4% compared to the AI. And these, again, the point is that the proportional risk reduction is the same. It's the baseline risk of recurrence that skews the absolute benefit. Now, what happens if you look at a sequence strategy of tamoxifen and aromatase inhibitor, as they did in Big 198 and multiple other trials? It begins to all smurf everything together. Once you get exposed to the AI at any level, it becomes hard to see major differences in the outcomes. Now, perhaps there are particular subsets that might benefit from an aromatase inhibitor. Again, data from the subset analysis of Big 198, making the point that women who had lobular breast cancers treated with tamoxifen only seem to do quite poorly compared to other variants or other treatment approaches. And similarly, in the ABCSG8 trial, which compared tamoxifen versus tamoxifen sequenced with an aromatase inhibitor, anastrozole, if you look at overall survival, the women who got tamoxifen alone for lobular carcinomas seem to have a less good prognosis. So in my own practice, I do recommend an AI whenever possible for women who have lobular carcinomas. As Prue was just discussing, therapies that have anti-estrogen effects have a lot of side effects. This is just a very convenient figure from the MA27 study, which looked at anastrozole or exemestane as adjuvant endocrine therapy to make the point that arthralgias, menopausal symptoms such as hot flashes and night sweats, sleep disturbance, decreased libido, and vaginal dryness are very common symptoms in postmenopausal women taking AI-based therapy and also taking tamoxifen. Indeed, these are the most common reasons that women stop taking their adjuvant endocrine therapy. Again, data from Big 198 pointing out that arthralgias are the single biggest contributor to interruption of therapy, followed by things like hot flashes, night sweats, and other sensations of generally feeling unwell. So what can we do about this? Because it's important. There have been other studies that have shown that the degree of arthralgias directly affect the rate of compliance. In this study, using a metric for arthritic symptoms, the greater the arthralgia score, the more likely the patient was to discontinue AI therapy. So how can we intervene to be effective? One strategy is to simply switch endocrine therapy approaches, and a variety of small single-center experiences have suggested that anecdotally switching a patient from tamoxifen to an AI, or switching AI brands, or switching from AI to tamoxifen is successful in somewhere between 50% and 2/3 of the instances. And in another experience, if you looked at the measurable degree of symptomatology, switching from anastrozole to letrozole with a 1-month washout allowed patients to resume therapy, usually with lower degrees of symptom scores, especially arthralgias. Dawn Hirschman at Columbia has done some beautiful trials looking at other interventions for AI-associated arthralgias. Omega-3 fatty acids are essentially a very nice placebo, and I often recommend them to my patients on that basis because they reduce the incidence of arthritic symptoms. Duloxetine, the antidepressant, can also reduce the incidence of AI-associated arthralgias, even more so than a placebo. In a very provocative study, she recently showed that acupuncture, when instituted for women who have AI-associated arthralgias, can achieve a diminishment in pain symptomatology, and many patients are now pursuing this. Now, not everything works to reduce AI-associated arthralgias. Anecdotally, NSAIDs are notoriously ineffective, as is acetaminophen. And in a randomized placebo-controlled study looking at topical emu oil for joint-related pains using an aromatase inhibitor, there was again no benefit, which I think is good news for all of us, especially the emus. In a brilliant series of trials led by Charles Loprinzi and colleagues at the Mayo Clinic, they have looked at hot flash reduction in women on adjuvant endocrine therapies over the years, and in a series of trials have shown that a variety of things will do the same as a placebo, including soy, flaxseed, and black cohosh, and several interventions can improve outcomes more than a placebo, including antidepressants, the use of pregabalin, and most recently oxybutynin, a drug used as a bladder antispasmodic agent. So the point of all this is to say that we have some interventions that can make these drugs more bearable for our patients. What do we do beyond 5 years of therapy for the woman who remains disease-free at the 5-year landmark? And Prue, in her discussion at the podium, just started to get into this issue. As you know, the single biggest prognostic factor for late recurrence of ER-positive breast cancer is the extent of nodal disease. For women who have node-negative cancers, it is the size of the primary tumor. And for women who have smaller node-negative cancers, it is the grade of the cancer. None of this is particularly surprising. You can also use genomic signatures to predict the risk of late recurrence. This just happened to be a very nice recent example from a population-based study where they showed that luminal A cancers free of recurrence after 5 years had a far more favorable prognosis than luminal B. And what's interesting to note is that even as the nodal stage goes up from 1 positive node to 2 positive nodes and then to 3 positive nodes, for the luminal A cancers, the risk doesn't really change all that much in the ensuing 5 to 10 years, whereas for luminal B cancers, it clearly goes up. Now, this is a list of the prognostic factors for late recurrence after 5 years of adjuvant endocrine therapy. And for those of you who are paying attention, you are correct. This is the exact same slide as the factors for recurrence in the first 0 to 5 years. Now, there have been recently reports of multiple studies looking at longer durations of adjuvant endocrine treatment beyond 5 years of therapy. Again, Prue alluded to the ATLAS trial, extending tamoxifen to 10 years. There have been multiple studies of an aromatase inhibitor after 5 years of tamoxifen. In the past couple of years, we've seen reports from multiple trials looking at AIs after AI-based therapy. And finally, there have been several reports looking at, in women who are getting longer durations of treatment beyond 5 years, what is the absolute best way to do it, or does a certain interval of time prove to be the best? And on the right-hand side here, I've tried to sort of give the range for the hazard ratios. Tamoxifen after tamoxifen, there's about a 25% risk reduction in recurrence. An AI after tamoxifen, around a 35% reduction in risk of recurrence. That's true if you bleed a little bit of tamoxifen into the first 5 years. For AIs after AIs, there's about a 25% risk of reduction. And once you get beyond 7 or 8 years of therapy, in the follow-up that's been reported for these other trials, it's hard to see that there is a major benefit for ongoing treatment. So for women who are nearing that 8-year landmark and are really uncomfortable or don't like taking the extended adjuvant endocrine therapy, there's high-level data that there's, at best, a really, really modest benefit. So these are data from the recent publication of the NSABP B42 study, a study of 5 years of letrozole after 5 years of either an AI or tamoxifen and AI-based therapy. And these are the outcomes looking at breast cancer-free interval or distant metastatic recurrence. Again, just to make the point that based on risk stratification, lymph node positive cases derive more measurable benefit than lymph node negative. In either case, you're talking about something on the order of a 2 to 4% risk in the average patient who went on to these clinical trials, presumably more risk in higher stage patients and less risk in lower stage patients. And Richard Gray presented data at the San Antonio meeting from the Oxford overview analysis of extended adjuvant endocrine therapy. And again, the quantitative measurable benefit is directly affected by the stage at presentation. With higher stage cases, there's more like an 8% reduction in the risk of recurrence. For node negative cases, it's barely measurable at 1%. You'll note that the relative risk is more or less the same across the board. Again, it's all about what the underlying risk is at baseline. There have been efforts to measure quality of life in women receiving extended adjuvant endocrine therapy. These are data from the MA17R investigators published last year. Interestingly, they're surprisingly the same for women who take extended adjuvant endocrine therapy versus not. Perhaps that says that these instruments are not granular enough to really capture the patient experience, but I think you can also take away that there's no major diminution in quality of life when you look at women taking an extended therapy, and that also could reflect, of course, self-selection. Those patients who have been very uncomfortable or don't want to take further therapy have already opted out. So what drives patient choice in this situation? So a survey done of 131 women at Michigan, and Dan, I do not think these were all your patients, though perhaps they could have been, who had been on endocrine therapy for 3 to 5 years, were asked, how willing are you to pursue extended endocrine therapy? And the interesting answer was that 85% were open to the possibility of pursuing extended endocrine therapy, and the principal determining factor of their willingness was their perception of the medical necessity of taking that treatment. So I think this is an instance where having those ballpark sense of the numbers, the realistic numbers, is very helpful for discussing the real-world trade-offs for patients. So here's a bit of a schema for tailoring adjuvant endocrine therapy, looking at anatomic stage on the x-axis and a variety of biological risk measures on the y-axis, including things like the quantitative ER&PR, grade, proliferation, your genomic signature if you wish, or if you want to use a shorthand bucket of luminal A versus luminal B. And it makes the point, I think, in general, that for slower stage, favorable biological tumors, standard endocrine therapy with 5 years of treatment is probably going to be the standard. And as you branch out from there in terms of either biological risk or anatomic stage, you're going to increasingly escalate the endocrine therapy approaches. This would include specifically encouraging a patient towards an aromatase inhibitor, using ovarian suppression if appropriate in a premenopausal woman, and extending the duration of adjuvant endocrine therapy in patients who are either pre or postmenopausal. So I want to conclude by thinking about some of the practical challenges in the modern era. This is that same pie chart I introduced at the beginning. Again, in very broad strokes, if you look at the right-hand side, you're looking at stage 1 and stage 2A tumors, which have what you might consider luminal A or low-grade features. And what's interesting is that this group of patients is doing very, very well in our recent experiences. So here are data from 3 studies that were alluded to by Angelo: the recent results of the TAILOR-X trial, the MINDAX study, and the West German Plan B study, all of which stratified patients with relatively low anatomic stage and favorable biological features to a treatment approach built around endocrine therapy alone. And in the instance of the MINDAX trial and the West German Plan B study, included a small number of node-positive patients. And what you can see in each of these trials is that the 8 to 10 year disease-free survival or metastatic recurrence-free survival is in the range of approximately 95%. And I just saw the data that Prue showed. If you take the favorable prognosis patients in the SOFT trial who were not advised to get chemotherapy, typically stage 1, lower grade cancers, again, you're talking about an 8 to 10 year disease-free survival in excess of 95%. These patients are doing very well based on a careful selection of anatomic stage and biological risk. So we'll conclude with the pie chart. Because for about half of all women in developed societies who are getting screening mammography, we are at the end game for management and intervention. These women typically have ER-positive, luminal A, stage 1 and stage 2A cancers. There's an extraordinarily low event rate. We saw that in some of the radiation therapy studies earlier today. We know that we need to follow them for 10 years, and both of those things provide tremendous challenges for trialists, because you need events to be a cancer trialist, and nobody wants to wait 15 years to write their first paper for an interventional trial. What we're also seeing, and Eric Weiner's remarks alluded to this earlier, is that for those women who have other subsets of breast cancer, which is no more than about half of all breast cancer, we clearly need to do better. And this includes the luminal B subset of breast cancers, higher stage luminal A breast cancers where there is persistent risk, a portion of the HER2 positive breast cancers that do not have stage 1 breast cancer, and the same for triple negative, though again, those are a distinct minority of the presentations of all breast cancers in Western societies. Thank you all very much for the opportunity to join you today. Best wishes.
Thank you, Dr. Burstein. I think we have time for one or two questions, please. Can we turn microphone 1 on, please?
Hello? Yeah, Andrew Rothman from Germany. In San Antonio, we saw some promising data regarding reducing the tamoxifen dose to 5 milligrams. Are there any research for reducing the AI dose, perhaps, for improving the adherence of them?
It's a good question. The question is whether reducing the AI dose would do that. I actually I'm not aware of any trials that are actively looking at that question. Others may know more about that.
There actually was an old randomized trial in a metastatic setting of letrozole at 2 different doses versus placebo, and the lower dose was closed because of an increased progression rate. So there is a difference in doses, and of course it depends on estradiol levels and what you need to get over it. So it's risky business to start reducing AI levels. You got to be old enough to remember that. Actually, Kent Osborne's in the audience. Kent, didn't you PI that? Or was that the anastrozole? You did the anastrozole. Anyway, other questions? Microphone 2.
Thank you for a very nice lecture. Dr. Sanat from Iran. As you mentioned in your slide, one of the important complications of aromatase inhibitor is bone complication of the patient. Do you recommend that bisphosphonate for treatment of osteoporosis or prevention of osteoporosis? And the other question is how long you recommended use of a bisphosphonate?
So that is a perfect segue to Rob Coleman, who will be addressing this momentarily. In our routine practice, we check bone mineral density every 2 years for women who have either premature ovarian suppression or who have aromatase inhibitor therapy, and we use standard WHO guidelines for initiating treatment for osteoporosis or osteopenia. I think a larger question that I'll defer to Rob on momentarily is whether or not to give these as adjuvant treatments, and there's been some interesting literature over the years.
Thank you, Hal.